of the day, and we have a very probably an important and timely session, which is on the pandemic and public health in Kerala, a topic which has engulfed the whole country as well as the whole globe. So I'm sure there'll be a very interesting discussion and topics that will be discussed. In chair, we have Professor Indu PS Indu, who is the professor and head Department of Community Medicine, as well as the nodal officer for the Institutional Research Committee at the Government Medical College, Kollam, Kerala. Professor Indu, can I request you to chair the session and take over?
Thank you, Dr. Chidambaran Iyer. And welcome to the afternoon session of this very important conference, Pandemic and Public Health in Kerala. We have three very important papers for this afternoon session. We'll start off with emerging infectious disease concerns and challenges for the health of Kerala. Following that, we have two other papers which are related to public health, of course, equity and economics as well. Second would be stigmatization and its impact on access to healthcare, situation of indigenous communities in Attapadi. Of course, in some of these recent weeks, there are certain events which actually brought to focus the equity in relation to tribal, and interrogating the Kerala model through the lens of health equity. That would be the third paper. All these are related. At the end of each presentation, we can take up a few questions which are very specific to that topic in focus. And at the end of all the three, I am thankful to all these speakers who have agreed to be with us till the end of the presentation. So at the end of all the three presentations, we can have an interaction on the common framework which and there's a common thread which all these papers have in. Let's begin with the focus area, the communicable disease in the context of emerging infectious diseases. Emerging infectious disease concerns and challenges for the health of Kerala. Dr. Anish is Associate Professor in the Department of Community Medicine, Government Medical College, Trivandrum. He has been in the public domain for quite some time as a public health activist. He is also the state chair of the Kerala, the health the academic part of the Shastra Sahitya Parishad from the activist side. He's also part of the Kerala disaster management team, especially in the context of COVID. He's also a member of the state level expert committee for management of COVID-19 on behalf of the government of Kerala. He's an astute researcher, excellent teacher and communicator. His area of interest is communicable disease epidemiology per se. Over to you, Anish.
Thank you, ma'am, for the wonderful introduction. Respected chairs, dear friends, warm good afternoon. Can I share my slides?
Yes.
Okay, I hope that my slide is visible. Ma'am?
It's coming up. Yes, now it's visible and clear.
Okay. Now I am going to speak about the emerging infectious disease, the concern and challenges for the health of Kerala. So my presentation has got this much content. At the outset, I am going to discuss about the Kerala's response to the first generation health issues. That is, overall, it is known as Kerala model of health, that Kerala responded to the first generation health issues. And in the second part of my lecture, I will be discussing about the response to epidemiological transition in Kerala, then emerging and re-emerging infections as a third generation health problems in Kerala, and the risk factors and threats, and the socio-economic contribution. I may not be going to detail to the socio-economic contribution because the other two sessions mainly concentrating on that part, and a slide on the way forward. So I would like to divide the Kerala's health issues into 3 generations. If you look at the first generation, the epidemiological situation was dominated by communicable diseases, the conventional communicable diseases, waterborne diseases, chest infections, malaria, and so many things, cholera, and so many things, and maternal and child health problems. When India got independence, Kerala's infant mortality rate was somewhere around 150. At that point of time in India, it was somewhere around 250. But Kerala has achieved a reduction in infant mortality rate from 150 to single digit. Now it is somewhere around 8 or 7. That is the infant mortality rate of Kerala nowadays. So that is one thing. That is Kerala's achievement in health through social development. The communicable disease control has happened through social development. That is otherwise known as Kerala model of health. It is already discussed in so many forums. Maybe Dr. P.G.K. Panikkar and Dr. C.R. Soman was the two people who put these things to the limelight. And one of the major features of the Kerala's response to the first generation health issue is the control over infectious disease. The infectious diseases were coming down. In 1965, Kerala declared as the first part of India eliminated malaria. So actually, if you look into the matter in detail, you can see that it is not through the intervention in health. Rather, it is through the intervention of sociological or developmental sectors that what it is as a part of the social development in Kerala, maybe female literacy, good water and good transport, maybe through education and so many other things, Kerala achieved a control over infectious disease because it is very easy to control infectious disease, traditional infectious diseases. If you are able to drink good quality drinking water, if you are taking care of your personal hygiene, then the infectious disease burden will be reduced. And another aspect of the response of Kerala to the first generation health crisis is the achievements in maternal and child health indicators that I have already mentioned. If you look into the maternal mortality ratio in Kerala, maternal mortality ratio means how many mothers are dying out of maternal related complication among 1 lakh mothers. In Kerala, it is somewhere around 30 or 35, but all India level, the indicators are more than hundreds, something around 100 in India, but Kerala is less than 1/3 of that. So these kinds of, if you look at the response of the first generation health issues, that is against the traditional or the old generation or old world communicable disease, we can see that the control over infectious diseases and achievement in maternal and child health indicators are very important thing for Kerala. And it was demonstrated by Dr. C.R. Soman. This is a slide directly from Dr. C.R. Soman was using these slides for his community presentations. So you can see that what happened in 1956. 1956 is the year that the state was formed. Until 2005, there is a large reduction in infant mortality rate and the CDR, the crude death rate, crude birth rate, total fertility rate. Total fertility rate is our average number of children born to a couple was reduced from maybe 5 to now it is somewhere around 1.6. Life expectancy has increased from maybe 50 to somewhere around 80. So many achievements were happening in this period of time. So that was the response of Kerala for the first generation problems. But if you move to the second generation problems that might have started somewhere around 1980, and it was actually peaked, maybe it is, we are on the peak now. The epidemiological spectrum of the disease started dominated by chronic non-communicable diseases. The communicable diseases were coming down and non-communicable diseases were going up. If you look into this slide, this is also belonging to Dr. C.R. Soman. You can see that infections contributed only 5% of total deaths. infections that you can see in magenta or pink color has contributed only 5% of deaths. If you look at the 95% of deaths in Kerala, this is the data from the Varkala cohort or pro-life cohort, you can see that 95% of deaths are because of chronic non-communicable diseases. And again, if you compare Kerala situation to that of United States or United Kingdom, where maybe people may be thinking that the capital of non-communicable diseases. If you look at the age-specific death rate because of non-communicable diseases, you can see that Kerala has got a higher age-specific mortality because of non-communicable diseases compared to even UK and US. So these are the second generation health problems which was dominated by non-communicable diseases. Definitely everywhere in the world, it is moving from communicable diseases to non-communicable diseases because advancing age, maybe we have got better life expectancy, maybe we have got good hospitals to take care of the infectious diseases. So an antibiotic will help to reduce the burden of infectious diseases, but non-communicable diseases, once it is treated, it is going to be there for a long period of time. So it is interesting to note how Kerala responded to this epidemiological change. Actually, it is not my topic, so I will just rush through. People believe, so many people think that Kerala failed to respond adequately to the second generation challenges. Because as the first generation challenges, we are celebrating Kerala model of health and development, but we do not have something to celebrate in the how or why we tackle the second generation problems, that is non-communicable diseases. And so many issues are there, privatization, maybe public. Now, if you just move to the period, maybe now Kerala is taking up this issue and the public health system is getting strengthened. We have got a dedicated program, Ardram and all. And if you look at the healthcare cost, you can see that during this period of time, Kerala model of health is famous for good health at low cost. But now it is a panacea. It is not reality that there is good health at low cost in Kerala. Kerala is the top one or the first state in India which is contributing much to the out-of-pocket spending on health. It may be 3 times or 4 times that of average Indian expenditure on health. So these things are actually happened, and you can read a lot of literatures on this matter. That is, I have just go through these papers. Low mortality and high morbidity in Kerala. People think that it should be reconsidered because as the elderly proportion of population is increased, there is high mortality is also there. Then how Kerala is taking up the challenges of chronic non-communicable diseases through Ardram. Ardram mission is the program that is based on the Sustainable Development Goals. One paper on that. Evolution of non-communicable disease programs in Kerala, lessons learned and way forward. So many papers you can refer to. And if I move to my topic proper, one slow epidemic or what something is happening in communicable disease spectrum also, unless you are very vigilant on that aspect, it is going to create a lot of problems. So now we are focusing on the non-communicable disease burden, which is contributing to a significant share of the epidemiological situation of the state. There is emerging and re-emerging infectious diseases. When there is an infectious disease is emerging and it has got a potential to create something like a pandemic, it is a very big threat to the global economy. So if you consider COVID-19 and maybe cancers or heart attacks, or that is myocardial infarction, COVID-19 has not killed so many people who are killed by a heart attack every year. But you know that COVID-19 has stopped the entire world, the entire life of the world, where the heart attacks were not able to stop our living. So if an infectious disease is going to spread like anything, then the challenge that is created by an infectious disease may be much more compared to a non-communicable disease, because largely non-communicable diseases are managed at individual point of view. But a communicable disease is largely, it is a responsibility of the community because it is able to spread among people, and it is spreading because of the interaction among people. So it is a very important thing that you have to focus more on emerging and re-emerging infectious diseases, because Kerala is a hub of emerging and re-emerging infectious diseases. What you are seeing in this slide is the list of first diseases, communicable diseases listed by DHS, that is Department of Health Services, Government of Kerala, in the year 2018 and 2019. Because of COVID-19, we do not have a list of diseases which is for 2020 and 21. This is the latest data that we have. You can see that if you look at both the list has got the same components: dengue fever, malaria, confirmed chikungunya, AES, that is Japanese encephalitis. AES is a suspected Japanese encephalitis, and the Japanese encephalitis confirmed. Leptospirosis. Leptospirosis is known as rat fever or elipani. Hepatitis A, hepatitis B, suspected cholera. These are the infectious disease. If you look at the first maybe 6 diseases, all are emerging or re-emerging infectious diseases. That means if you look at the epidemiological situation, especially that of infectious epidemiology in Kerala, you can very clearly see that the epidemiological situation was taken by, or it is imbibed by, the infectious diseases, that is emerging and re-emerging infectious diseases. If you look at the infectious disease spectrum of Kerala and when it was originated or when it was first reported, you can see that the leptospirosis is a notorious disease. If you look at the floods of Kerala, leptospirosis kills more number of people than people killed by flood itself. Flood will create leptospirosis outbreak after flood, and the number or the killing power of leptospirosis is much more than compared to the floods. That is not only in Kerala, everywhere the communicable disease that is occurring after the natural calamities will kill more people rather than the natural calamity itself. In case of Kerala, actually, we are better. Leptospirosis or elipani, which was started only in 1989, is the first year reported leptospirosis case from Kerala, that is from Kolancheri. And Japanese encephalitis report started only from 1994 onwards. Malaria, you may be thinking that malaria is an old world disease. Yes, malaria is an old world disease. Even people believe that the great Alexander the Great was killed by malaria. But in Kerala, in 1965, Kerala became the first state declared that malaria was eradicated. But for the another 25 years, Kerala was reporting not a single case of indigenous malaria, that is malaria that was developed from the state itself. But in 1995, there is a large outbreak of malaria affected the heart of Trivandrum city, that is Valiyadura outbreak. So now, even now, we can see that malaria is contributing to much of the epidemiological situation. Scrub typhus, otherwise known as Chellupani, in Kerala, it was actually started or detected maybe after 1995. Leishmaniasis or Karimpani. So people of Kerala has given different names for these diseases because a new disease is coming. Then based on either based on the clinical features of that disease. For example, Takalipani, that literally mean tomato fever because the lesions created by this disease is resembling tomatoes. So something like that. Karimpani is Kala Asar. The Malayalam name is for Karimpani. If you look at the dengue fever, again, it was started in 21st century. Chikungunya, only from 2006 onwards. Chikungunya is actually a very interesting case study for Kerala. Not only for Kerala, for other part of the world also. Because chikungunya was a virus which was detected way back in 1957 in Tanzania. For a half a century years, that is maybe for 50 years or so, chikungunya was not reported anywhere in the world other than its original place, that is the East African region. But what happened in 2006? Scientists believe that one genetic mutation that has happened in chikungunya virus was responsible for this rapid spread. because so many mosquitoes were able to transmit this. So that is, for us, it is important mosquito species is known as Aedes albopictus. That is very rampant in Kerala, and this particular mosquito was able to take this virus from a person and to give another person. So a genetic mutation can create a very big burden of communicable disease. Now people are looking at another mosquito-borne disease that is where there in Africa and South America, that is yellow fever. Yellow fever has got a killing power of 60%. If some genetic mutations is happening, yellow fever is actually an old virus. Maybe the chance of genetic mutations might be much low compared to chikungunya or some other virus. It's all true, but if that is happening, if this disease is going to transmit other part of the world, it is going to have a high death toll, and it is going to stop our entire life because of the spread of the disease. Because these mosquitoes are everywhere in the world, and if the virus is going to adapt to the mosquito, then the things may be very difficult. Another issue Kerala nowadays facing is Casinur forest disease, that is KFD. KFD is otherwise known as Kurangupeni. So this is the natural reservoirs are monkeys, and some ticks from monkeys can collect this virus and give to human being. This is a biosafety level 4 virus. Biosafety level 4 virus means the highest biosafety level is the biosafety level 4. That means these viruses can even used for bioterrorism and maybe for organic weapons and all. So these problems, these are a few among the list of the threats that we are facing. So this is the time that we have to focus more on the new generation for emerging and re-emerging infectious diseases. So Kerala has got a lot of risks of transmitting these kinds of diseases because of the one is rich biodiversity. You know that Kerala is a biodiversity hotspot, and there is a continuous close human-animal interaction. The Nipah is actually a case study for how much close human-animal interaction is there. Even Kurangupeni or KFD is another case study that this is happening in Kerala. Otherwise, why we are reporting Nipah cases for the last 5 years, and anywhere in the world is not reporting Nipah cases. Maybe other states of India may not be reporting Nipah cases, maybe because their reporting capacity for the surveillance activity in that area may be poor. But why other countries are not reporting Nipah cases? Nipah indicates that Kerala is a hotspot for viruses that can emerge from animals. You know that COVID-19 is a virus which is emerged from animal. So deforestation and fragmented habitats. Deforestation was from my forestry friends from forestry department. I came to know that deforestation is not an issue nowadays. It was happened in Kerala till maybe 1990s or the start of 21st century, but now it is not the issue. The other thing is the issue, that is fragmented habitats. That means if people are there, maybe the location, or people are residing inside forest areas, people are moving. If they want to move from their habitats to the adjacent city, they have to cross the forest and all other things. And demographic transition and age structure is another challenge that we have faced in the time of COVID-19. That Kerala, if you look at the proportion of elderly population, if 65 year is the cutoff, in Kerala, around 15% of people are across this particular cutoff. The Indian average is somewhere around 8%. And that means Kerala, the proportion of elderly population is double that of India. And we know that the Kerala is the morbidity pattern is highly dominated by non-communicable disease. Kerala is largely a morbid population. Any infectious disease which is going to strike Kerala, the damage can be much, much high compared to any other part of India, maybe compared to European, or Scandinavian, or maybe other countries, developed countries. And if you look at the population mobility and migration, that is also very important for a disease. That you know that Omicron was there in Africa. We were detected Omicron in South Africa, maybe last part of November, but we could not prevent that entering to any countries, because population mobility is a very important concern. And we know that every disease has got something known as incubation period. And during this incubation period, we are not able to find out the cases, or we are not able to pick up the cases. Even the person suffering from, or the person harboring the virus, do not know that he has got the virus inside his body, so that he can move and he can give the disease to the other people who are in contact. Second one is these people can move from one place to another. It is not from maybe one village to the adjacent village. It is actually moving from Calicut to Dubai. So the disease which is collected from Calicut can be manifested in Dubai, and the people who are coming in contact with this person can be affected in Gulf countries. So this much mobility is there, and Kerala population is, if you look at the average mobility, Kerala is a highly mobile population. And if you look at the migration, the extent of migration may be number one in India. So then another issue is the consumerism. Consumerism will bring a lot of challenges. One, I am actually focusing on the meat markets. So these domestic animals, especially the culling of domestic animals and maybe butchering of domestic animals, are very important. If you look at the meat industry of Kerala, it is not at all monitored. Every meat or these cattle are coming from adjacent states. They are not routinely examined. These cattle are going to each and every nook and corners of the state, and it is butchered there and sold in every villages without even getting a certificate that these animals are free from diseases. So this is actually a challenge, that we know that COVID-19 was originated from China, from a wet market. That is the most important theory about the emergence of COVID-19. So these kinds of things can happen at any point of time, because so many diseases are there among animals. Unless you are monitoring this animal movement through this state, people are thinking and arguing about the other health hazards of maybe eating meat. Maybe people are thinking or using it in a cultural context, but definitely we have to think and debate on the emergence of new diseases also. I'm not telling that we have to stop eating meat. Meat is actually a rich source of micronutrients as well as rich source of protein. So maybe nowadays chicken may be the richest and cheap source of protein for Kerala. So nothing wrong in eating chicken or meat or something else, but we have to have a thorough monitoring of these things. Solid waste management issues are there. Solid waste may be the reason that there is high rat population, high dog population, and so many issues are there. I'm not going into details. Even solid waste management is the real issue behind the large outbreaks of even leptospirosis in Kerala. People think that the dengue outbreak that is currently occurring in Kerala is because of the failure in solid waste management issues. And climate change is a reality, that you know that the change in rainfall has contributed to emergence of so many diseases. Because of climate change, the rainfall is changing. Rainfall will alter the mosquito population as well as the population of other insects also. Mosquito is the commonest insect, contributing to large number of outbreaks of emerging communicable diseases. But not only mosquitoes, so many other insects are there. For example, sandflies. Sandflies are small insects, maybe in the size of 1/3 of a mosquito. It was seen in tribal areas, but now we are getting a lot of sandflies from the Trivandrum city itself. So that is a real challenge. Sandfly is transmitting a dreaded infectious disease, which is known as Kala-Azar. In every month, we are detecting Kala-Azar from Kerala, and I will not be surprised if tomorrow, maybe 10 or 20 years, if there is a large outbreak of leishmaniasis, that is Kala-Azar from Kerala. So climate change is a reality. Because of climate change, the arthropod population is dominating, and the areas where there is no mosquito breeding in the previous years are getting these areas are prone for mosquito-borne diseases, and all other things are happening. And if you look at the enforcement part, you can see that the enforcement is very poor. It is not only even the hospitals are not having these kinds of enforcement mechanisms. You may be heard about the antibiotic resistance and all. Antibiotic resistance means if you consume a lot of antibiotic, or if antibiotics are going to go to the earth, or antibiotics are used in other areas, for example, animal husbandry, if we are using for maybe fisheries, antibiotics can go to water and the soil, and antibiotic-like substances. For example, so many insecticides will resemble antibiotic. Some other agents that we use can also, some chemicals can also soil can alter the organisms, microorganisms, and these microorganisms, which is able to tide over the antibiotic, can create another pandemic. That is another theory or another postulate that future pandemic can be because of bacteria which has got resistance to antibiotic, and human beings may not be able to tackle these things. This is a very famous picture from a paper that was published in Nature in 2008. And they are telling that there could be large outbreaks of infectious diseases because of 4 reasons. What you are seeing in A is the infectious diseases that can emerge or start from wild animals, just like our COVID-19. So this paper was published in 2008, and they are telling that these are the hotspots for diseases that could emerge from wild animals. So southern China is also considered as a hotspot. Another hotspot is India, especially northern India, and you can see that Western Ghat is also a hotspot for emerging infectious diseases from wild animals. Second reason is emergence from domestic animals. And third reason is antibiotic resistance. And fourth reason is a outbreak or a large pandemic contributed by insects, especially mosquito. If you look at this picture also, you can see that Western Ghat is another hotspot. That means Kerala or Western Ghat is considered as a hotspot of emergence of new diseases because of 2 reasons, especially because of 2 reasons. One is emergence of diseases from wild animals, and second one is emergence of new diseases from insects, including mosquitoes. So this is another picture. I am just showing you the picture. You can see that this is avian influenza. There are 2 diseases which is highly prone to create pandemic. One is influenza and second one is corona. You can see that influenza every year in Kerala, we are reporting influenza, but among migratory birds and our ducks, in every year in Alleppey, we are killing thousands of ducks for this particular thing. That means we are prone for a new avian influenza. So another avian influenza outbreak or a pandemic can be started from Kerala. So Kerala is highly prone for those kinds of problem. This is KFD, that is Casinur forest disease. As the word indicated, Casinur forest is a forest area in Shimoga district of Karnataka. Till 21st century, the disease was only localized to that particular districts. But from 2015 onwards, 2 districts in Kerala has reported human cases of KFD. One is Wayanad and second one is Malappuram. And we have detected the presence of this virus among monkeys in Alleppey district. So this is a, as I have already mentioned, this is a biosafety level 4 virus, which has got dreaded complication once if it is spreading across the state. You can see this is the Nipah belt. Nipah belt means the natural habitat of the fruit-eating bats which could transmit Nipah. And the entire India is inside. Maybe India is the large country which is completely inside the entire Nipah belt. And again, we are prone for these kinds of large outbreaks because of this dreaded disease of Nipah. This is dengue fever. That is the #1 insect-borne disease in Kerala. And this is the Indian map. The reds indicate that high burden of dengue. The entire state of Kerala has got high burden of dengue fever. So this is the situation, but this is about migration, and you can see that migration is high in Kerala. This is the age structure, which is dominated by elderly population. Compared to Bihar, you can see that the bottom of our population pyramid is very narrow. That means the children are less and elderly population is more. This is a paper that is published in 2022. Now, it is just last week, and I and Dr. Indu are authors. And I am actually showing this picture that you can see that, especially the lowest, the A, B, C, and D are the 4 serotypes of dengue virus. And you can see that D is the last serotype, that is type 4. Type 4 dengue virus was not reported in 2017 and 2018, but in 2019, the green sign, that means not report. The other thing, yellow is maybe less than 5, maybe 2 in numbers. Orange maybe less than 4 in numbers, and red is more than 5 or something like that. We can see that the emergence of new viral strains, even in case of dengue, we are suffering from emergence of new strains of dengue. The emergence of 2 new strains of dengue is actually a challenge, because if one new strain is happened to spread in an area where the other strains are spreading, the people affected by the new strain are more prone for complications of dengue. That is that is known as antibody-mediated enhancement and all other stuff. That can happen. That means it is we might have suffered from COVID-19 multiple times. The second time, the COVID-19 used to be milder. That is actually, luckily, it is happening that the first infection is giving you some kind of a partial immunity. But in dengue, this is not the case. The second infection may be more severe. The first infection make it more severe. The second infection will be more severe. That is because of this mechanism. People were fearing these kinds of mechanism in COVID-19 also initially, but luckily it was not happened. So again, for references, I have given some papers, and I am not going to details. And then the socioeconomic contributions are also very important in infectious diseases. So this is a statement from the Upper Silesia report of Sir Rudolf Virchow. You might have heard about Rudolf Virchow, because Rudolf Virchow is the messiah of social medicine, who was a German doctor who was investigated a large outbreak of typhus in Upper Silesia, maybe the last part of 19th century. And this is a famous quoting from his report. Medicine is a social science, and politics is nothing else but medicine on a large scale. Okay. Medicine as a social science, as the science of human beings, has the obligation to point out problems and to attempt their theoretical solution. The politician, the practical anthropologist, must find the means of their actual solution. So what happened in Upper Silesia was actually poverty. Poverty was leading to an infectious disease. People are getting typhus because of poverty. If we want to solve this problem, the poverty should be solved, not the disease, but the cause of the disease should be solved. Why poverty in Upper Silesia? It is because of these people were under the rule of Prussian Empire. These people were not able to take care of themselves politically. So he was advising at least a partial freedom for Upper Silesia. Even maybe first in the history of mankind, freedom is suggested as a treatment for a disease. So this is the importance of this thing. So if you look at the society of Kerala, you can see that so many people are underprivileged, and that may be a reason that these kinds of diseases are more among them. And we know that if the diseases are going to be transmitted or clustered in a particular area or among a particular group of people, in no time it is going to transmit to other people. So the presence of the marginalized communities inside a state or inside a society is a large risk for the entire society, because communicable diseases can concentrate. It can get the momentum in these groups and it can be transmitted. I am COVID-19 is actually a case study for that. And you can see that COVID-19 acted as a litmus test, and it revealed areas where we have to get more focus. Urban areas where urban slums were affected more, coastal areas were affected more, colonies were affected more. And now we know that these are the areas where we have to focus. So I am just putting two things. This is a famous paper on Attapadi issue. I know that this is going to discussed in detail. Everything is provided free, but they are still hesitant to access healthcare services. Why does indigenous community in Attapadi, Kerala continue to experience poor access to healthcare? This is a picture. It's a notorious picture. I think it is the coastal area of Trivandrum, where the commandos are there to frighten people to stick on to COVID protocols. So this was not happened in any part of our state, but it has happened in coastal area of Kerala. We people are thinking that the people living in coastal area are people not able to control by the usual mechanisms, and maybe that may be the attitude. So these kinds of attitudinal change should also be changed. Otherwise, we cannot tackle the new generation health problems. That is maybe because of emergence of communicable diseases. So this is my last slide. Way forward, so many things are there. So many things could be discussed. I am not going into details. The public health advocacy is a very important thing. That means we have to tell authorities, because in Kerala or elsewhere, in India also, there is no mechanism to take the evidence from the literature and to implement in the field. The researchers themselves has to show that, or the advocacy is a very important aspect in India, I think, because but if you look at the UK, whatever things published in maybe in literature, at least in NHS, it could be used because of the intervention of NICE. One health approach is a very important thing. So infections, previously we were looking at infections, trying to treat them, and then we realized that it is not enough, because infections are not because of the individual's action, but rather it is because of it is a social product. If an area where there is no good quality drinking water supply, then definitely there will be high chance of waterborne diseases. So rather than treating the child who is suffering from diarrhea, you just give them good quality drinking water. That was the approach that we used. Now the approach is again changed, that not only this human society, it is very important definitely, but along with the human society, we have to look the animal society, because from where these infectious agents may be coming, we have to look at the microorganisms present in these localities, and we have to have a very comprehensive approach, that is One Health approach. And comprehensive, all-inclusive primary healthcare. Primary healthcare is very close to our heart. Primary healthcare is the capacity building should happen each and every nook and corner of the world, maybe in the state, so that people can take care themselves. We cannot provide health. We can only generate or synthesize health with the help of people. So concentration of social determinants of health, strengthening of surveillance, that is a very important thing, because we are not knowing what is happening in our state, because our surveillance mechanism till even now it is poor. So definitely there is some improvement, but it is poor, and we have to have a very good system so that these kinds of challenges will be taken or by the system at the early phase of it itself, so that we can have tackle these issues. And system building, that should also be maybe as a part of system building. We have got a lab, that is the Institute of Advanced Virology, Thonnakal. That is a very good move, but definitely it should have. We have to move further, because in COVID-19 we know that we don't have a single institution which can have entire genome sequencing for this virus. We have to send it to Delhi or Pune and to get it done. At the start of COVID pandemic, we were having only one lab which can do PCR. Now we have got a lot of lab because of the pressure induced by COVID-19. So that kind of a poor system where we are working, community engagement is a very important aspect because we experienced the worth of community engagement in COVID-19, not only in COVID-19. The community engagement was the heart of even Kerala model of health. And if you just take away the political part or political argument from COVID-19 management, you can see that Kerala is a state where which is managed COVID-19 pretty well, irrespective of so many risk factors, including the proportion of elderly population and all. But it is only because of the community engagement. We were trying to use so many resources that is available in community. We may not be counting it, the people's help, but definitely we were using this cooperation from the community, especially in flood and all. You know that we are taking advantage of the community engagement. And enforcement, really, that is very, very important. And now we are moving to a particular act, that is Kerala, the Public Health Act. That is a very good move from government, because the last Kerala Public Health Act was way back in 1955. We have got maybe an act which is aged somewhere around 70 years. And now we have got a very good Public Health Act which may be coming up. Those good signs are there, but enforcement is very important. And research, that is also very, very important, because these are the new problems, emerging problems, that we have to research it out and we have to find solution at the outset itself, so that we can prevent these kinds of issues in future. So I stop my session or lecture now. Thank you. Thank you for patience.
Thank you, Anish, for that very comprehensive presentation. If there is one question also very specific to emerging infectious disease, we can take it up for a few minutes. Otherwise, we can move to the next paper. Anish, I think we will come back to you after the 3 papers. Hope that's okay, Anish.
Thank you, madam. Okay. Thank you.
We move on. Related to this only, actually, Anish was talking about the social capital, the social determinants, Rudolph Virchow, Upper Silesia stories, freedom, and several other determinants. Also, some of the enforcement kind of, someone tried to engage the community through that. So it's a continuation only, but there is a lot of stigma, other social determinants, the excluded or the marginalized. Stigmatization and its impact on access to healthcare. Situation of indigenous communities in Attapadi. We have a very eminent presenter for this, Dr. Sunil George. He's a public health researcher from Kerala who did his master's from the London School of Hygiene and Public Health. He's currently doing his postdoctoral in the University of Canberra. He has extensive experience in working with these communities other than India, from Kenya, South Africa, and Australia. His PhD thesis was on the impact of social exclusion on access to healthcare among indigenous communities and the older widows living in Kerala. So this also happens to be related. I think all these CDS topics are really, connected to each other, and we can continue the discussion thread forward. Stigmatization and its impact on access to healthcare. Dr. Sunil George. It's visible. The slides are visible.
Indu, can you see my screen?
Yes, we can.
Hello?
Yes, we can. Very clear.
Okay, I can't hear anything.
Can you hear me, Dr. Sunil? The slides are visible.
Just a second, I'll just stop sharing and then just check this.
I can.
Just a minute. Okay, let me just try this time.
The slides were very much visible. Yes.
Okay.
Please go ahead.
Okay. Thank you so much, Dr. Indu, and good afternoon, everybody. I would like to start my presentation acknowledging that the University of Canberra is situated on lands which originally belonged to the Ngunnawal indigenous people, and I pay my respects to their elders past, present, and emerging. I would also like to acknowledge and pay my respects to the elders of the Muduga, Kurumba, and Irula indigenous communities of Attapadi, past, present, and emerging, whose stories I will be sharing with you today. Now, when we talk of health systems, there is this popular notion that the key focus of a health system is to be concerned with well-being and to make use of the best available evidence to improve practices and to produce outputs related to healthcare. But health systems have also been conceptualized as core social institutions, which are not only concerned with the production of health and healthcare, but with a wider set of social norms and values. And when we look at this from this particular theoretical angle, the values, priorities, and social norms of the society in which a local health system is placed, as well as the values, priorities, and norms of key individuals who are in the health system, plays a very significant role. Now, I'm not going to spend a lot of time here. All of us know about this, rightly so. I mean, I've always been proud whenever I go around the world, I say I'm from Kerala and we have the best health system. And it continues to lead the country in all the classical indicators. Now, the term good health at low cost, I first heard it when my mentor, Dr. Iqbal, told me this at a conference, but you should thank the Rockefeller Foundation for it. The first time this term was used was in the 1985 Bellagio conference, where Kerala was the only state. All the other comparators were countries such as China, Colombia, and all of that. And this term has stuck with the Kerala health system, and again, rightly so, that good health can be had at low cost. Now, how did Kerala manage this? I mean, there is a whole historical reason, and Kerala always had an organized system of healing related to Ayurveda and the presence of Vaidyans. Every family almost had their own Vaidyan at some point in time. Definitely my family had 2 generations back. You have the Hortus Malabaricus, which was based on Itti Achyutan's writings, really. The openness shown to vaccination, and there is this fascinating paper which has come out in 2019 by Aparna Nair on how different social groups, including a lot of socially excluded communities, were brought under vaccination coverage in the kingdoms of Tiruvankulam and Kochi. We talk a lot about matrilineal society, and Robin Jeffrey has this phrase that he says that it's not just the ability of women to attend public school, but also to be seen as attending public schools had a big impact. Definitely the land for the tiller movement and the land reforms, which were brought by the first communist government. And of course, investment in public health, public services, including health and education until the 1980s. But Kerala always had stigmatizing, stereotyping, and othering of certain communities, certain groups happening. Robin Jeffrey uses the term the old Kerala, where he describes the complex caste systems, the penalties for so-called pollution, even the breath of a lower caste person could pollute and all of that. But social reformers challenged the status quo and also the lack of access to resources, including education, the health system, and all of that for the socially excluded communities. But over the last 2 decades, there have been so many instances of stigmatization, stereotyping, and othering. And I just wanted to mention 2 instances which are very famous, where I was personally involved. The first one was in Kaidakuri in Kollam, Benson and Bensi, who had to fight a big struggle to get back to their schools. And the other one was Akshara and Anantu in Kottayur, where I was lucky enough to go and conduct ethnography. And this is a picture of Akshara and Anantu in their separate classroom, looking into the regular classroom where other children were there. And it took actually a long time the science movement, KSSP played an important role. But more important than that, actually, if you see this picture, these two other children, these two boys who are between Akshara and Anantu, their parents broke the stigma. They said that we are going to send our children to that separate class. Even if our children get HIV from Akshara and Anantu, we are going to take the risk and send. We can't set these children away and stigmatize them like this. So Kerala has this eclectic mix, this boiling pot, where we have a lot of progressive things happening, but we have so many instances of stigmatization, stereotyping, and othering. And this was in the year 2004. These were the two most famous, but that year there were 10 instances, starting from Cheruvattur in Kasaragod district, right up to Neyyatingara in Trivandrum district. 10 instances of children who were kept outside their schools because of their HIV positive status. So now, when we come to Attapadi, before I talk of Attapadi, I want to tell you a small story which probably none of you know. The first instance of infant death in Attapadi, not a single media house in Kerala was willing to publish. It took an indigenous community group to dip into their networks, fly in a reporter from Bombay, and the first report came in the Sunday supplement of the Bombay edition of the Indian Express. And this was what was seen by the then Prime Minister Manmohan Singh, who called the then Chief Minister and all of that. Why I mention this is that, like, even yesterday I heard one of the presenters say that, Kerala media doesn't want to, engage with some of these difficult issues. And if you look at how media has been reporting Attapadi ever since 2013, it is a lot of superficial discussion that goes on. Nobody asks serious questions about why things continue. So coming to Attapadi, Attapadi is India's first notified tribal block, and now it has become a taluk also. The Muduga, Kurumba, and Irula communities live, and today they live in 192 villages spread across Attapadi. The last census clearly showed that now the indigenous population is in a minority. And in 2013, there was this shocker, all across the country. How can this happen in Kerala? Kerala is the leading state. So what is going on? But the center and the state responded to this situation. Now, what did the governments do? When I look at this, there are three angles in which the government decided to approach this issue. The first was revamping the local health system. So it upgraded the health facilities. It appointed a lot of staff with special incentives. If you choose to work in Attapadi, you straight away get a 20% bonus on your basic salary straight away. They call it risk allowance. Now, every government officer there gets this risk allowance. Then you have free inpatient, outpatient, and super specialist care. Everything, including medication that you can take home, over-the-counter medication, is free. There is a special scheme for pregnant women called Janani Janma Raksha, where from your first trimester, you get paid through direct cash transfer, 1,800 rupees for 18 months. The idea is to motivate you to come for antenatal care, but also to actually give you money to have nutritious food. What more can any government do? The next is addressing malnourishment. So they started community kitchens, which is now being wound up. They started nutrition rehabilitation center, where they had the severely malnourished and moderately acutely malnourished kids. They were treated, and they started the millet village scheme for reviving traditional agriculture, but it was done in a top-down fashion, but still it is going on. They're trying to tweak it a bit. But the millet village scheme also had this unexpected outcome of several indigenous movements who have never practiced agriculture suddenly becoming agriculturists when the minister visits Attapadi. So just a side note for that. Now, the third thing which the indigenous community always asks, right from Jairam Ramesh, who came as a special emissary, to TK Nair, all of them said the basic issue is alienation of land, return the lands. Everybody acknowledged this. Everybody, even today, acknowledges this. There were mechanisms that were set up. Some indigenous have been provided landless pattas. Some indigenous landless were provided some pattas, but it was not near their traditional living area. It was provided in a very different area where some of it was in the elephant corridor. Some of it, they said, it is rocky, we can't practice agriculture. Now, to ensure that all these three three approaches work well, they set up an intersectoral coordination mechanism under the sub-collector of Ottapalam, and this meets every month. So all program heads, NGOs, panchayat presidents, MLA, all of them come and they discuss problems and try to find solutions. So all of this was done. But if you look at the papers on and off, you will hear Attapadiyil Meendum Shishumaranam, Attapadiyil Sambhavikkunnathu Endanu. These titles keep coming. So this is what got me very interested. What is really happening there? I mean, what is going on? So if you look at the IMR, yes, 2013 stands out, but after so much of money being pumped in, so many buildings being built, so many resources, doctors, nurses, ANMs, JPHNs, all being posted there, why is this still continuing? And this is the latest statistics that are available that I could get for you. Now, I'll just briefly tell you about the methodology. I carried ethnographic fieldwork. I lived in Attapadi. I obtained permission from various departments to live inside the Adivasi villages. I carried out ethnography in 2 phases. I had to leave Attapadi in October 2019 because, as all of you know, in October 2019, something happened in Attapadi and there was what they call the encounter of Maoists. So every outsider was asked to leave Attapadi. We could not enter the villages. So till then I was there. I lived and collected data in 19 villages. I also visited all the health centers. I carried out participant observation, carried out focus group discussions, in-depth interviews. I also visited 2 successful indigenous health projects in South India. Now, my results were validated using member checking of various forms, but my results were also corroborated by an internal report of the ITDP, which spoke of some of the things that I have discussed in my paper, as well as I'm going to present here. This is just the sampling framework. I'll move on. If you have any questions, you can ask me later. Now, I would like to spend a little time to tell you about Attapadi and its location, because I'm going to keep referring to some of these names. I'm so sorry that I can't blow this up further. So this is the border to Tamil Nadu. You enter from Coimbatore here. This is where the route coming up from Mannarkad. This is Mukkali, where you enter Attapadi. This is again Tamil Nadu. This is Silent Valley, and this is Attapadi Reserve Forest. Now, this is Galisi. I lived in Galisi. Now, this is another extreme Mulli, and this is Moolaganga and Vellakulam. Now, this is the key place. Kottattara Government Tribal Specialty Hospital. This is the specialty hospital that was highly upgraded. You have a community health center in Agali. You have 3 PHCs, Sholayur, Anakatti, and you have it in Pudur. And all over Attapadi, these blue dots, I'm sorry, they might not be very visible. There are very good functional sub-centers, and in most sub-centers, there are at least 2 JPHNs who are living there, actually living there. They have quarters, proper electricity and all of that. Some sub-centers are closed, like the one here in Anavai, nobody goes and lives there. You also have St. Peter's Hospital, which is run by missionary sisters. You have Vivekananda Hospital here, which is run by the RSS. And just outside, when you cross the border here in Anakatti, you have Bethany Hospital. Now, what happens if a woman gets pregnant in, let us say, Idavadi, which is inside the reserve forest? It is, it takes you, I mean, you have to climb 2 hills and cross 1 river only. So if a pregnant woman, a young girl gets pregnant in Idavani and she needs antenatal care, she has to come down this route. She has to cross the Varagar here. It's the river there, tributary of the Bhavani. She has to again cross the Varagar here. Swarnagada sub-center is there. No, you cannot get any care here. Okay, she keeps coming down this route. PHC Pudur, which is an upgraded family health center, which once upon a time used to admit patients and treat them, is here. No, you will not be given antenatal care here. So she has to keep coming down this route, keep coming down here, and come to Kotatra Hospital. Every service is only provided in Kotatra Hospital related to maternal and child health. There are plenty of doctors here who are sitting here. There are plenty of doctors, at least two doctors, two medical officers and two medical officers who man the mobile medical unit here in Choliyu. There are doctors here in Anakatti. No, but you have to come. If you are in Vellagolam again, you have to come. Now, the problem is not just the terrain. It depends on your fitness. I used to take 8 hours to move from, I'm reasonably fit for an urban 40-year-old privileged man, but I used to take from Mele Galisi to come up to Anavai. I used to take around 5 to 6 hours and then wait for a 4x4, which had to come all the way here. And then from here, I have to come here and then come all the way here. It depends on your fitness. It depends on the state of your pregnancy. I mean, when you are first trimester, second trimester, final trimester. It depends on the season. It depends on the time of the day, because wild animals, like this route, for example, from here down here, after 5 o'clock, nobody goes here because elephants take over the road. Don't even ask me about what happens in this place when it is dark. So women had to, or anybody else, had to be carried in a hammock or tottil, as they used to call it. And that costs 2,000 rupees. You have to cut bamboo and, do all of this and bring. But there are doctors sitting here. There is an upgraded PHC, family health center. No, there is a CHC here. You can't even get antenatal care here. If you want to ask me why, I will definitely address this later in the discussion. Now, when I went there, I found these two categories, the good Adivasi and the problematic Adivasi. Who is the good Adivasi? This is not explicit. This is not written in any documents or guidelines or anything, but these things, over time emerge. The characteristics of the good Adivasi are somebody who follows all the rules that is laid out for him. So Adivasi women in Attapadi had to come every month for ANC. So somebody living in Mele Galisi, it is a 2-day trip to come, wait among 80 or 90 people, wait, meet the doctor for 10 minutes and then go back. So the good Adivasi person, the good Adivasi young girl will always ensure that she never misses her ANC. If you miss the ANC, you're a problematic Adivasi. If you don't come and stay for a week, sometimes for 2 weeks for delivery in the hospital at Kotatra Ashutri, you are a problematic Adivasi. And some of them said, if you miss 2 antenatal checkup, they have been come and asked, the Mattavammar here are referring to Maoists. Did they come and tell you don't go to the hospital? Why are you not coming for? So this used to create a lot of fear. In fact, when I first went in, I was suspected to be a spy. It took several months for me to move from, is this man a spy, to, is this man mentally okay? Why is he staying in the forest with us and doing all of this? To becoming what they used to call me. I mean, the young people used to call me the Kashandi doctor who wears a lungi. So that move from the external expert to the emic perspective. But if you go, an outsider goes there, people are scared. They will tell you exactly that everything is fine. We have no problems. And that is exactly what I had in my field notes in the first 3-4 months. Now, this is not just about the health system. This was the approach of the entire development of indigenous communities. And this led to a lot of marginalization. I'll give you a small example. If you go to Kotatra Hospital, even today, if you manage to go, get a chance, please go to Kotatra Hospital and just spend some time, without identifying yourself. You will see young men, some of them have matted long hair. Now, how this was perceived by the clinicians and the others was that this is an issue of hygiene. These guys don't listen. Their wives are pregnant and even then they come around dirty without combing their hair and all of that. The indigenous tradition was very different. If you love your wife, you will grow your hair. You know why? because your wife, according to them, is no longer sexually available for you. So you should not become very attractive. So you should grow your hair. It should be matted, and you will wait for her to deliver, and you will then cut your hair, and then you will have physical relations, intimate relationships with your wife. I mean, but this was seen from a different thing as these guys are dirty, but that was not the case. So marginalization of so many local customs and traditions and all of that. Now, this is a quote that a young person told me that പട്ടികജാതി എന്ന് ഞാൻ കേൾക്കുമ്പോൾ തന്നെ ഐ നോ ഞാൻ നിങ്ങളുടെ ഒരു ഭാഗത്ത് ഐ എം നോട്ട് പാർട്ട് ഓഫ് യു എനിക്ക് ഒരിക്കലും നിങ്ങൾ ഒരാളാകാൻ പറ്റത്തില്ല. So when the people use that term, they have so many ideas about that we are some wild savage people living in the forest. Now the next thing, I mean, like in the previous presentation there was this whole thing about armed escorts. I will tell you more about armed escorts. Compliance was enforced with good intention. And please, I mean, like I would like to emphasize this, that all the directives and enforcing compliance, all the doctors were really good at heart. And they also pointed out that, look, there is so much of pressure on Attappady. One child dies, the media will come here, your minister will come here, and we have to become a scapegoat. Somebody will have to become a scapegoat, and it will usually be one of the junior doctors. And this did happen in 2018. Now, what fascinated me when I went to Attappady, I was asked to, because I had taken permission and all of that, and the government had allowed me to go in. I was asked to attend the coordination committee meetings. And the sub-collector used to tell the doctors, don't take armed police and go. The community will not trust you, but the doctors would refuse to go. So doctors never enter any village without armed, and I'm emphasizing the word armed police. Now in 2018, I will not tell you the name of the village because then I will break confidentiality. A young pregnant girl was forced into a police jeep. Her hands and legs were tied up and taken to Kottatra hospital so that institutional delivery will happen. Now, the last known instance was in 2020 when Thunderbolt Force, not the ordinary police, Thunderbolt Force surrounded the house of a pregnant woman whom they called a problem case. She is not listening, complicated pregnancy and all of that, and took her this one. Now, everybody in Attappady knows all of this. This does not cross Anakatti border or cross Mukkali border. Everybody in Attappady knows about all of this that is happening. But outside the borders of Attappady, nobody knows about this. Now, this is a quote that one of the women who was forced to go, not tied up, but forced to go, asked me, I understand you. I understand what you're trying to do. But let me ask you this. Do you understand me as a woman? Do you understand me as a mother who has 2 children, grown-up children? I have multiple responsibilities. You are telling me to go and I get admitted for 14 days. How can I do that? But you force me to do. What do I do? So now, when I was there in 2018, infant deaths were happening. One of the questions that I found very fascinating, but very strange also, was this question that why do these women not cry when their children, ഇവരെന്താ തല്ലി അലച്ച് കരയാത്തത് ഈ അമ്മമാരെല്ലാം? ഇവർക്ക് അവരുടെ കുട്ടികളോട് അടുപ്പമില്ല. In fact, once when I was visiting with an Adivasi friend of mine, and this was said by a very senior official, I was literally praying, sitting, that he will not get up and hit him, because I could see him trying to control his anger. And when we came out, he was like, "Enda sare, ഞങ്ങളുടെ പെമ്പിള്ളേരെ കുറിച്ച് ഇങ്ങനെയാണോ പറയുന്നത്?" Even animals cry, they have emotions. So stigmatizing women, and therefore this is guilt by association. ഇവളുമാര് മടിച്ചികളാണ്. I am deliberately using Malayalam words so you get the actual import of these statements. ഇവളുമാര് മടിച്ചികളാണ്. They will not provide. കിടന്നുറങ്ങും. അതുകൊണ്ടാണ് മുല കുടിച്ച് പിള്ളേര് മരിക്കുന്നത്. The community was, as I mentioned, totally outraged at this comment, and this, demeaned the women. But we all got away with it because we are privileged. I want to specifically focus on this curious case, as I call it, the curious case of milk aspiration. Now, any infant who died at their home, the case was immediately said to be milk aspiration. Now, in 2018, I mean, from a public health perspective, what was called the index case happened in one of the distant villages. I went around in 2018 conducting verbal autopsies in every house where an infant had died. Now, what was very interesting for me was that this was the case that we used to be always pointed out in the meeting, saying that the woman slept, child got up, drank, she breastfed her lying down, and there was milk aspiration. Paal kudichu maranam. The doctor who went to do by the time the health system came to know that, because it was a very remote village, the health system came to know that this child had died. They had already finished the burial ceremony. They had not seen the child. There was no post-mortem report. See, what will a woman say if you tell, "Ningada kuttiki paalu koduthaayirunnu"? What will a mother say? A mother will keep feeding her child this one, and therefore immediately it was paalu kudichu maranam. Now, this theory went for a 6 on this exact date when a child who was admitted in Kotatra Hospital 1 hour before the time for being discharged died. And again, it was termed as milk aspiration death. And this led to a major issue in the next day. We had the coordination committee meeting when the doctors were pinned down and asked, how did you come to the conclusion? They said, actually, sir, in the report, we have written probable cause. So we really don't know. Then they were asked, then why did you use the term milk aspiration? This was what they were told. Now, every child who dies in Attapadi compulsorily, even if it is against their religious beliefs, post-mortem will be done. That is the standing order there. Now, what did the post-mortem report say? I'll show you an extract, which is completely blanked out. I'll show you what the post-mortem report says. This was what was written in all the post-mortem reports. Opinion as to cause of death reserved pending for laboratory findings. And that some histopathological investigation has to be done, and this tissue has been sent to this lab and all of that. In only one report, there was a mention saying milk-like substance found in lung tissue. All the others came to this. So where was the evidence to say that all these children were dying from milk aspiration? I mean, as a public health researcher, scientist, I mean, I don't see any evidence. Let me show you something else. I mean, most of you are based out of Trivandrum. In 2019, this statue came up in the foreground of Kotatra Hospital. Just have a look at these two statues. The other statue, I took this picture in Trivandrum Medical College Hospital. One of the young Adivasis who were working in the hospital called me and asked me to go and look at the statue when I went there. And he asked me, I said, what do you mean? So he asked me, see, you have gone to and lived in the remote forests. Have you seen any woman, any Adivasi woman, any woman from our community who doesn't cover their breast? I was like, no, I have not seen. Then why have you people created this? See, this is again your dominant community's idea that we are savages. Now, I did tell this to a friend of mine, and he said, Sunil, now don't make a big issue out of this. You go to any medical college, you will find a mother and a child breastfeeding. That is standard. So that is why I went to Trivandrum Medical College and I took the photo. Kindly have a look at the statue in Trivandrum Medical College. Even in the breast that is being, used to feed the baby there, the blouse is etched out. I went to Alappuzha Medical College also. Same story there. So, I mean, this is nothing but, like, to me as an ethnographer, this is a manifestation of that stereotype about indigenous communities. Now, one interesting, among the many interesting, the other interesting that I think that came up in my data was that not one person, in the 47 IDIs that I did said, this is our hospital. They said, this is not our hospital. Now, direct acts of discrimination were rare, but unconscious bias was evident. I told you about the death of this child on 22nd November 2018 in Kotatra Hospital. On 23rd November at 9:30 in the morning, there was a very, very curious protest from Kotatra Chanda, which is like 5 minutes walk from this hospital, to the entrance of this hospital. The guy in the front was carrying a pail of small bucket of paint. All they wanted to do was they wanted to paint over the word Adivasi and tribal on the notice board. They wanted to say symbolically, we want to say, this is not our hospital. Of course, the police came and broke up the protest. They couldn't do that. But to me, it was very fascinating that, a group of young tribals decided to carry a bucket of paint, and all they had no other objective. Our children will continue to die, but we'll just paint it over. It is not. So the lack of ownership there. Now, since 2013, multiple probes and studies have been ordered to find out, what every time a child dies, the minister or somebody else orders a probe. Why are these reports commissioned? Where are these reports? Have these reports and their findings informed the health system? In fact, this is a quote from a very senior pediatrician who has worked for several years in Attapadi. So he was like, you tell me what kind of a study we should do actually to find out the causal links to sudden infant death syndrome, which is happening in Attapadi. Do you think, 5 people coming here, taking a jeep and going around 10 villages and writing, a 10-page report will find out? You need to conduct a proper epidemiological study, which will take years, but nobody wants to do that. Now, my question is this: would this happen with a dominant community in Kerala with strong political connections? No, it will not. I can tell you because I come from one such community. Now, to conclude, my last slide. See, access to healthcare, especially with this movement to universal healthcare and universal health coverage, has been problematized as an issue of infrastructure and finance. Attapadi is a clear evidence that these two are not going to be silver bullets, and they are not going to improve access to healthcare for vulnerable communities. Stigma, discrimination, and stereotyping are well-known barriers. Now, health systems can be agents of transformation, or they can enforce the dominant status quo. From my work during my PhD, from the evidence available, the local health system in Attapadi enforced the dominant status quo. Not only that, unfortunately, it was actively involved in marginalizing the indigenous communities. And this further exacerbated inequity and led to, and continues to lead to, poor access and outcomes. I would like to thank Dr. Devika and the Center for Development Studies for giving me this opportunity to present in front of you, and I would be happy to take questions.
Thank you, Dr. Sunil George. It was just, though I say it's a continuation of Anish's presentation, of course, there are certain very specific areas like the emic ethic perspective, the stigma related ones, the relate, as you said, as an ethnographer, your perspective. Probably we can discuss lots of such issues during our discussion. May now move on to the third paper in the session, interrogating the Kerala model through the lens of health inequity, poor borders. Dr. Rakhal, actually, Anish also mentioned about the Kerala model, the initial papers, and Dr. Sunil George's Sunil's presentation also discussed some of the real life examples of how the so-called model can be questioned from the excluded communities' perspective. Dr. Rakhal is professor in public health at the Menon Center for Health Science Studies, which is an autonomous institution for public health under the Sri Chitra Tirunala Institute of Medical Science and Technology, Trivandrum. He's an alumnus from the Christian Medical College, Vellore, and he has his European experience. He had this PhD from Sweden. His major area of interest is non-communicable disease. He also works with the government. He's also a member of the working group on health of the Kerala State Planning Board. So let's complete today's discourse on inequity. Dr. Rakhal, interrogating the Kerala model through the lens of health inequity.
Yeah. Thank you very much, Dr. Indu. Sunil, may I request you to stop sharing? I'm unable to share. Yeah, is my slide visible,
Yes.
madam?
Yes,
Okay.
yes.
Okay. A very good afternoon to everybody, and thanks for this opportunity. It is always a very tough job to follow on these such wonderful presentations, and I do hope that I will be able to build on the sort of thread that has been developed over the last 2 days. Before I start off my presentation, I think a few disclaimers are in order. So I am a relatively new entrant into the Kerala scene. I joined the Achyuta Menon Center in 2019. I was thrown in the deep end thanks to the COVID pandemic, and have been involved with the COVID expert group for the government of Kerala. But apart from that, there's very little, direct, field level involvement, with Kerala. And therefore, I see myself, in a way as an outsider, but also, more and more, trying to sort of understand, things from the inside. And I take that outsider status and the naivety it brings, and I acknowledge that and bring that into my presentation quite consciously. What I propose to do in this presentation is not really make any any clear sort of final sort of statements, or propose any final sort of conclusions, but merely propose and show certain gaps and disjunctures that have come to my mind, as it were, in an attempt to sort of begin a discussion on certain issues that I haven't really seen being actively discussed, at least within the broad circles of the dominant discourse in and around health in Kerala. I pick up on a few specific themes, and the whole topic of the so-called subnational exceptionalism, as it was termed in the whole gender session yesterday, the first session of the conference, I think is something I will sort of pick up, and this has been referred to again by both Anish and Sunil in their presentations when they sort of evoked the Kerala model. And I think I will sort of build on the presentations both in the gender session, and, for example, the presentation by Abhilash yesterday, and what Sunil talked about today, to really question this the functioning of this so-called exceptionalism, or the so-called model, using data that is freely available on in various reports and so on. So what I will do really is I will focus on a range of parameters, but that are not traditionally focused on. And what I will do really is focus on inequity, social gradients, and rather than look at statistics, as at a cross-sectional, in a cross-sectional way, I will attempt to look at trends over time and see what these patterns throw at us. So I'm not really focusing on the statistical validity of individual numbers, but rather look at the trends, the gaps, and the gradients that are, I think, pretty visible when one is looking at the data. I will try to throw light on dissonances between this mainstream discourse of Kerala achieving the SDGs already and the data that is thrown up, especially when one looks at it in a disaggregated fashion. And what I will do is also throw at that, or begin to engage with what this pattern is showing, using theoretical insights not in a sort of way of explaining or explaining away, but rather to engage with the experience, that is being thrown up, that is being attempted to be reflected, by this data. And I will end, as I said, more in terms of, proposing, points for debate, than anything else. So what are my central questions? I think, to me, I think the starting point of my, quest really was the 1995 paper by, Dr. John Kurian, and I was so thrilled to hear him speak again, yesterday, where he talks about the central tendency and the outliers, and that to me was the starting point, of the way I looked at these statistics, and I said that rather than focus on the central tendency, which is quite clear to all, what I wanted to do was really focus on what happened over time to the so-called outliers. And in this way, I'm also sort of acknowledging, Shilpa when she talked yesterday, as a privileged researcher, the responsibility, as it were, to go against the grain of dominant discourse, and I hope that in some small way, this presentation attempts to do that. I ask, therefore, why do social gradients exist or persist, rather than ask the question, why has Kerala achieved an IMR of 7? And I'm asking a very different question here, and I will elaborate on that, in the presentation. And I ask, how have we understood these gradients, and are there any hints as to the mechanisms for the sustenance of these gradients? So I do not ask about questions of associations and regressions and statistically significant p-values, but I ask the sociological question of mechanisms that will animate and create these trends and gradients. The way I reached these conclusions that I'm presenting to you in this conference is basically through 3 broad engagements that I had over these last 3 years. One, of course, is through engaging with various policies in the health department that focus on and target the groups who are identified as marginalized. This is through my more recent work with the State Planning Board as part of the working group. I also engaged with the data on nutrition and hypertension, disaggregated with social group classification. This was a small little exercise that I did using the NFHS data, the fact that it was just released, the NFHS 5 data, and I will be presenting a little bit of this. And then, of course, engaging with data coming out of a range of studies. I have worked along with Sunil. I was, on the doctoral committee of Sunil when he did his PhD. I was also involved in, supporting, a student community from Pundura. Again, a photograph shown by Anish about the commandos standing there. I don't know if it's Valyadura or Pundura, but basically the coastal community, and supporting students there who have submitted a paper on their perspective on the whole episode, which has been accepted for publication in EPW. So it was also those engagements with marginalized communities, that I draw on as I make my presentation. Now, I start off with a couple of slides where I explain my conceptual apparatus, which essentially starts with the British epidemiologist Sir Geoffrey Rose, who pointed out to us, in the early 90s, that the causes of disease are different from the causes of distribution of disease. And I think this fundamental issue, is actually the sort of fundamental core epidemiological principle that we follow, all the way from Rudolf Virchow onwards, where they talk about the social determinants. Now, the point that I think Sir Geoffrey Rose was trying to make is, therefore, a point that is that if we focus on high-risk groups, on those with the disease, then we may not really make any impact on social gradients of disease, which have very, very different determinants. This was whole approach has been built up on the Commission of Social Determinants of Health of the WHO, and essentially the commission talks about the health equity, but health equity having both what are called intermediate determinants and so-called structural and social determinants. So by the time we reach the 2000, virtue has actually been brought into mainstream epidemiological theory, public health theory, and we talk about the importance of labor market, of housing, of land, of education and social protection, and culture and societal values as being important in actually defining equity in health. This social determinants of health framework builds on an equally influential conceptual model by D.A. Derrickson, who essentially talks about the importance of social position in actually defining, for example, differential exposure to risk factors, differential vulnerability to those risk factors to actually transforming into disease, and then subsequently differential consequences of the disease itself on groups occupying different social positions. And what this really entails, as the Commission on Social Determinants of Health points out in the subsequent work that came out on saying what do we do on for social determinants, is that they, again, building on, for example, the principle that Sir Jeffrey Rose helpfully pointed out, said that when we make policies, we need to differentiate policies or intervention that attempt to overcome unequal consequences, that overcome specific vulnerabilities, and to overcome specific exposures. And what they point out is that these three are very different sets of policies compared to policies that are required to overcome stratification or processes of social stratification that lead to particular groups and individuals within groups to occupy particular social positions. So there is a very clear, theoretical, differentiation between the causes of inequity in a given society and the causes of specific diseases in an individual. And that really is the schism, the gap that I attempt to sort of use in a way to interrogate the, statistics as I see them. I round off my conceptual apparatus set of slides with an allusion to the fundamental cause theory, proposed by sociologists Link and Phelan, first in '95 and an updated version of their theory in 2010, which essentially talks about the fact that if we see diseases as socially determined, we see that diseases are driven, or inequities are driven, by what they call fundamental causes. Link and Phelan talk very clearly about capitalism. They talk about fundamental causes driving, the inequities in health. And they talk about the fact that these fundamental causes influence multiple disease outcomes, meaning that it's not limited to only one or few disease or health problems. It affects these diseases outcomes through multiple risk factors, and it involves access to resources that can be used to avoid risk or minimize the consequences of disease, and the association between a fundamental cause and health is reproduced over time via the replacement of intervening mechanisms. What does this mean? It means that you can overcome a particular inequity through a particular coercively imposed or widely covered intervention. But if you do not remove the fundamental cause that is driving it, then inequity emerges either in other diseases, in other dimensions, or through other mechanisms. And that is a fundamental insight, again, which I hope to draw on in my presentation. Now, what do we see in, for example, the NFHS5 data that has been, recently published? Now, just about a note on the timelines. NFHS3 was published in 2005-6. NFHS4 pertains to a time 2015-16, and NFHS 14-15, and NFHS5 pertains to the time 1920, right? So we are having an almost 15-year period, that is covered by these statistics. Looking at a cross-sectional area, a cross-sectional, graph, which just looks at the prevalence of hypertension at the time of survey, right? So at the time of survey, blood pressure was taken for all women between the age of 15 and 49. And what we see is the gradient. And all I'm pointing out in this slide is the presence of a clear gradient if you look at the number of years of schooling. Now, one may argue that those without schooling are older women and therefore would not naturally have a higher proportion in hypertension. Fair enough. But the point I'm trying to make is the presence, a clear presence of a gradient, a social gradient. I'm taking another example of NFHS5. This is moderate anemia among children under the age of 59 months. And here again, you see a gradient. This time I'm using, data based on their caste or Adivasi classification. So as you know, most administrative data is classified as either being SC, ST, OBC, and others. And others is a catch-all phrase which basically counts all non-SC, ST, OBC category. This is the way NFHS measures it. And again, you find this very clear gradient that is present. And now you must understand that this is the same health system. These are the same doctors. These are the same overall health system that has achieved the phenomenal outcomes in the traditional maternal child health indicators, that Dr. Anish presented the historical slides of Dr. Soman and others, but it is the same health system that is actually leading to, for example, or sustaining these gradients. And my question is, we need to start moving from looking at averages to gradients. Now, here is another slide, and this is looking at inputs. Okay, the previous slide was looking at outputs or outcomes, and this is a slide on inputs. And this is a question that asked the mother how many of the mothers or how many children received supplementary feed from the ICDS, from their local ICDS in the past. I think 1 year was the time period given. And essentially, this is a proxy for services actually being provided and utilized. Now, here you see again the gradient, but the interesting point in this slide is that actually, if you look at the ST community, the Adivasi community, those classified as ST, there is almost 70% of children are actually receiving some services. Okay. And if you look at the others or the non-SC, ST, OBC, it is actually only 50% of those children who are actually, getting services. And there is a neat, gradient between the two. So this gradient is actually a flip of the earlier gradient where the SC, ST, or the so-called Adivasi community, had the worst outcomes. What I will do now is to actually put these two graphs together, because the message and I think the story that these individual graphs say is very different from the story that when these graphs are put together. When seen separately, we talk and we think about, okay, how do we improve the situation? When we see the two graphs together, we realize that this is a very counterintuitive graph, because the group that actually takes the most inputs or gets the most inputs from the institutional apparatus are the groups with the worst outcomes. And the group with the least inputs, proportionally least inputs, are those with the best outcomes. Now, what does this mean? And I think we need to reflect on what are the implications of this. and I will pick these up a little later. Let us look then at trends over time. So if you look at the trends, and these are just point estimates in the 3 NFHS reports that I have graphed. I haven't done any sort of major statistical work on this, and you will see that in NFHS 3 we did not have good data, we did not have adequate numbers for the Adivasi community, and therefore they were only a report of SC, the others, and OBC. You find that over time, there seems to be a sort of plateauing from NFHS 4 to NFHS 5, but we see that the group that is considered others has been gradually increasing the benefit, has actually been increasing their usage of services. So while the usage of services or utilization of services has increased, say, from 46 to say 60% among the so-called those classified as SC, those classified as others or OBC has moved up from 20 to 50%. And there seems to be an almost plateauing of the use of the services by the Adivasi community. And how then has an indicator like, for example, stunting, which is height for age, below 2 standard deviations, how has that moved over time? Okay, and again you find the most obvious happening, at least in this visually, is that if you look at what has happened in the NFHS 3 period and what is happening in the NFHS 4 period, there seems to be at least a reduction in the gap. There is a persistence in the gradient, but definitely obvious reduction in the gap. But if you look at the NFHS 4 and NFHS 5 period, you find that the gap actually seems to be worsening, right? Of course, we talk about COVID, you can, throw in demonetization and, other various, lack of employment and so on. But the point is that this was the same system. This was the same health system. And in fact, the investment in this system has been increasing throughout this time, right? And especially since the Ardram mission in 2015. So what are we really seeing? Why are these trends? And again, rather than looking at these two graphs separately, if we put them together and then look at the trends in the inputs and the trends in the outcomes, again, we see this disjuncture that, between, for example, the almost, plateauing, for example, of the Dalit Adivasi community utilizing services, but yet a significant worsening of their overall, stunting over this time. Again, I'm looking at trends, and I'm just looking at a visual representation of those trends. Now, let's move on to say the antenatal checkups, right? And this is something we're all very proud of. Everything is over and above 95%. And what you see here is this tight coupling, right? Among all 3 or 4 communities, you really can't make out any major difference. There is a very mild sort of, gap, but then it's not really, significant in any way. So this underlines the fact that if the government wants, and we know how antenatal care is happening in some marginalized communities, Sunil alluded to it, and the coercion that, is part of it, but I will not go there. I merely am looking at statistics to show that it is possible for traditionally prioritized health services that are provided by governments to actually, in a way, reduce, overall, inequity, at least in provision. But you find, for example, screening for cervical cancer, what you find really again is, and these are very low percentages, no doubt, but if you actually look at the relative, you find that actually double the number of OBC or other, non-SC/ST OBC women are actually getting these services compared to, for example, Adivasi women, and it's actually double the quantity, double the magnitude, and therefore you find that in those newly introduced services, probably there seems to be a gap in the services, whereas in traditionally provided services the gap seems much less. But please note that all these services are provided by the same health system, right? And to me, that really is the question of why then do we find these gaps, these trends, these gradients. I want to finally, just present one more small set of slides, which basically looks at the BMI, the body mass index among women. And this is a specific slide that looks at a body mass index of more than 25, which is basically overweight and obesity. Now, what one finds, and this is well known, I think, in general, that there has been a gradual increase in the BMI, the proportion of individuals with a BMI more than 25, and NFHS 5 actually pegs it at around 40% for those in the OBC or the non-SC/ST OBC or others, as it is called. I would draw your attention to the number of women in the Adivasi community, and it seems almost rock stable at around 20% over the last 5 years. If you look at the number of women with a BMI of less than 17, you'll actually find Adivasis dominating and actually having much higher. But the point here is that you have a certain trend of increasing obesity among women, but a plateauing of that in the Adivasis. Now, obesity is one of the important risk factors for metabolic diseases. Now, what happens if we actually look at metabolic diseases? And here is a graph on stage 2 hypertension. This is, of course, not a clinical diagnosis of hypertension. This is an indicator that is reported by NFHS in their surveys, which basically talks about individuals who have a high systolic or diastolic reading at the time of the survey, or who are diagnosed as hypertension and are on or off treatment, and all of them are then put together in this category. Now, I am specifically reporting using the graph for those who had a systolic reading on or off medicine and or who don't know they are hypertensive, all of them together, of 160 on 7 or 7 up to 160 to 179 systolic. And for the benefit of those who are not familiar, the normal cutoff is 140 and the diastolic between 100 and 109, and the cutoff is 90, right? Now, what you see on the trend, and that is what I want you to look at, is that there is a tight clustering, and not actually tight clustering. It's actually 3 times those so-called others, the non-OBC, non-SC/ST community has about 3 times the proportion of hypertension reading at that particular day reported in NFHS 4. But what you find in NFHS 5 is quite remarkable, where you find that the Adivasi community is actually now reporting 4 times higher isolated measurements of hypertension, right? And of course, ST community, the Dalits, are also rapidly increasing their proportion of individuals that are showing hypertension. So what one actually finds is that the group then that has the most stable or plateauing proportion of obesity actually for some reason has this almost huge jump and steep jump in the number of people having a high systolic or diastolic pressure, and not just a mildly high, but a significantly high systolic and or diastolic reading, right? So the point I'm trying to make is that we in the health system traditionally go with, for example, traditional risk factors like, for example, obesity or waist circumference, which is also reported in NFHS 5. But if you look at outcomes, and if you look at the outcomes in relation to the health, to the risk factors, then we are thrown up with graphs, or trends that are pretty difficult to make sense of. And why is this happening? And to me, I think that is a question that we urgently need to start looking at right? Rather than, the question of, IMR, which is, 4, and when, yeah, sure, I think we need to keep pushing our IMR down, but unless we begin to start asking the questions of inequity, I think, we will be, missing the boat. This paper that I'm quoting from has been quoted in all 3 presentations today, which is, I think, quite a remarkable feat, and congratulations to Sunil. It was quoted by, Anish in his presentation, and of course, Sunil's paper itself formed the backdrop of his presentation, and I'm just picking up a few quotes from that paper, basically to animate the question of the first problem I showed, which is the fact that those who are actually using the services the most are actually having the worst outcomes. And of course, we know that that is because of the larger poverty, the land alienation, and a whole range of issues. But from within the health system, as Sunil has, so eloquently, shown, it's absolutely, the way in which the individuals are treated within the health system. And this, of course, is from a particular area, Attapadi, actually, leaves a very bitter taste in terms of, and to me at least, begins to explain the mechanism why so-called, utilization is not actually being transformed or translated into the outcomes that we would expect to see. I'm not going to read these because I think we've had adequate demonstration of this in Sunil's presentation, but I would like to definitely spend another half a minute on the work with the coastal community, and I'm really glad that Anish showed that photograph of the commandos there, and it was a lament that I heard in that community that said, just a few years ago, we were the community that was fated by the government when we went and did so much of rescue in the 2018 flood. It was from this same village that boats went out and saved people, and look, within 2 years you have commandos entering our village, and the feeling of hurt, the feeling of an enduring tragedy. Women and men talk to me about talk to the researchers about the shooting that happened in the 1960s, about the Oki rehabilitation and the lack of rehabilitation that they talked about in many instances. So what I'm trying to talk about is that at approaching such communities with a historical approach, a cultural approach, is actually detrimental to moving public health goals forward. The policy analysis, and I'll just, please don't try and read too much into this slide. I basically looked at the Day-Dixon framework and plotted and tried to show that all the health interventions like mobile clinics, the super specialty hospital, the free care, the compensation, all of those that Sunil actually talked about are actually only focusing on these 2 end chain links in the chain. Whereas the issue of exploitative markets, the issue of middlemen continuing to exploit, Adivasi communities, the continued non-resolution of land, of livelihood, the educational gaps, right, are hardly, which all contribute to social position, and the continued, ecological vulnerability that, Dr. Kurian talked about yesterday, for example, are continue to remain, to fester. And my argument in this presentation is that when that is happening, when that is being allowed to fester without, really moving forward, merely providing, health, interventions is really not going to do very much in the gradient, in the social gradient. And arguing, again, very, very tentatively that we are seeing a shift, for example, in, inequity to the non-communicable diseases. And I would argue, and I would, hypothesize that in the next 5 to 10 years, that is where inequity is going to be seen. We are going to be seeing a huge inequity in hypertension, in diabetes, and in deaths related to stroke and cardiac disease, because we are focusing so much on traditional individual level infectious disease or maternal child health, that in my opinion we are completely losing the game, as it were, in the and going back on fundamental causes. We are not doing anything to fundamental causes, so that driving force of inequity is just going to be deflected onto newer dimensions, and there are newer dimensions that are going to open up. Summarizing, the tackling of inequity or the social gradient requires different strategies than tackling specific diseases, and this cannot happen through interventions in one department alone. The mere expansion of infrastructure without exploring the ways in which social power hierarchies embed upon institutional functioning will not translate into the envisaged outcomes. In other words, consumption does not equal to the envisaged outcomes. And assuming that it does, in my opinion, is lazy thinking. A narrow focus on a particular disease without tackling the underlying root causes is unstable, as many indicators seem to have shown, at least in the post-COVID era. And a narrow focus on particular disease, which may be a priority in a given public health framing, without tackling the underlying root cause, will only shift the mechanism of the persistence of that gap, or shift the gap to another disease. And rather than propose a way forward, which I think would be way outside my scope, I would like to pose a few questions and ask really, how do we move from policy for specific disease control to policies to tackle the social gradient as a whole? Of course, this is outside the traditional boundaries of the health department, but will the health department take leadership in this to advocate for policy making that follows the understanding of social determinants of health and move towards, for example, health in all policies? To what extent is the health system and the LSG a platform for actually voicing and addressing the concerns of the most marginalized groups in Kerala? And I merely need to draw on the presentations, both, for example, of Malu and Souvik in for example, the first presentation in the first session yesterday, and for example Shilpa and Devika and Anamika's presentation, to draw from there onto, for example, the presentation made by Sunil just before me, to ask the question on what really have been the platforms available for the marginalized groups to transform health systems into systems that actually tackle this gradient, and what is the extent to which we can address health inequities in a situation where communities and institutions are embedded in and constrained by macro policy that in fact generates the inequity. And I'm talking here about fundamental causes. Thank you very much for your time. And
Thank you. Thank you, Dr. Rakhal. That was an outstanding presentation which summarized all the three, breaking the barriers of individual departments and moving out to address the social determinants. I'm not sure, Dr. Iyer, is there one or two minutes more, a few minutes more, because 4:30 was the upper limit of the time allotted to us. Is there a time for interaction?
I'm sure we can
Or
go
shall
until
I-
5 o'clock. That is for sure.
Okay, okay. Thank you, Dr. Devika. I thought 4:30 was the upper limit of the time. So it was an excellent thread that is coming out of the discussion, as there is an interface between the academics, the research, public health, activism, all that, because most of the work that have been presented are part of the academic activities and research activities, and that is getting connected to the actual reality in the field. I think we can take off first. Dr. Devika, what's the pattern like? Are we taking up questions from the audience and coming back to
Yes.
the speakers? Okay.
Yes, yes, please take questions from the audience.
Okay. Okay.
I'd like to ask something first.
Okay.
if you
We
let
can
me.
start. Yes.
Well, I
Please,
think
Dr. Devika, yeah.
this session, if you ask me to characterize it in one line, I must say this is a tight slap on the smug faces of those of us who have fattened our egos on, Kerala's social development achievements. I mean, we all know. I mean, there is this slight element of bad faith, in all of us. We knew this. We knew that things were bad even in the 1990s, and it was going downhill. We all knew that. But there is a way in which the whole idea of Kerala as this paradise of social development and healthcare props up our egos. And I think this was almost a spiritual exercise, especially, Sunil's presentation, Rakhal's presentation, image of or the quotes that you showed us, and the image of those commandos standing in that coastal village. I tell you, this was excellent, not just for the intellect, but even for the soul, if I may say so. But, I wanted to ask, I'm asking you as a historian. So in India, we know that the history of public health is inextricably bound to the history of colonialism. And in colonialism, we know that it was again very closely bound with the need of colonialism to control epidemics, which would have affected international trade, and therefore, it's very bound. It was bound with the economics of colonialism, the gain that the colonialist made out of the colony. And therefore, public health had nothing to do really with the well-being of people, etc. And in Kerala also, we have that, in Kerala, of course, we were fed with a different story. We are told that, of course, public health in Kerala deviated from that after the 1950s, at least in the 1950s until 1940s of the state of Travancore offered it as, the face of a benevolent government. But there have been stories in the 1930s of the Travancore government actually burning up working class areas in Alleppey, for example, to prevent the spread of the plague, etc. Forcible eviction of people to prevent. But those were supposed to be side stories, things that we just kept on the side. But when I was listening to Anish's paper, all three actually, what came to my mind was a question whether we really have ever gotten out of the colonial mold of public health. Have we really rid ourselves? Because, when Sunil said that there were doctors who would not go to villages without armed escorts. Now, what does it mean? What kind of state is that? Definitely not the welfare state. Is it the colonial state? Is it the colonial state which is now shamed, shamed, and it wants to cover up that shame? Anyway, this is for all three of you. What is the kind of state that we are seeing in these acts?
Okay. Thank you. Actually, when the Public Health Act comes up and the enforcement comes in a more, clear and strategic way. I mean, those are the days ahead. I think it's a very relevant question, Anish. Actually, I have a live experience. Actually, that was my first day with the fresh batch of MD students in that coastal area. We were interacting with the local people and the church when all of a sudden we heard the sound and the commandos were just marching in, and it was a real. I still can feel the surprise and the threat that we felt. They were young, MD interns also. Such a surprise, and I think we hope such an experience will not. We will not have to repeat that again in the field. Anish, colonialism, governance. Yes.
Yeah, ma'am. I don't know how much I can explain or how much I can discuss that matter. But I think there is a bit of colonial attitude in public health always, because it is dominated by doctors mostly. May not be in Kerala alone. If you look at any part of the world, it is dominated by medical people. Once in Kerala, all of them were trained in UK. And if you look at the different public health departments, or especially hospitals, medical colleges, maybe first primary health center that was started in 1930 at Neyatankara, all of the people were trained in UK and they were following that kind of an attitude. That aspect is there. Even now, if you look at the the culture that among doctors, you can see that there is a bit of colonial attitude that they are thinking maybe they are superior and they have got some kind of a division between the public to them to whom they are serving. And this particular science, that is medical science, not only public health, the medical science is also such a science that it is very difficult to, there is a gap between the people and the person who is giving the service, and there is some kind of an autonomy is there because of this thing. But if you look at what happened, especially in Kerala, maybe during 1950s and 60s, we were moving to another stream. That it is primarily because we were not moving through the public health stream, rather we were moving through the development stream. So as a part of social development, we were getting some output in public health. So that aspect that we have achieved at that point of time, I don't count it's a part of colonial attitude or colonial methodologies. But maybe down the line, I think we again lose that culture. And we were able to, as the other Rakhal sir and Sunil sir has pointed out, we were not able to build upon that. And again, as Devika madam has pointed out, we are remained with this kind of social inequalities. And again, there is nothing to be privileged or nothing to be proud of in this particular
Anish,
reality.
there is also a question in the chat box whether the data in relation to COVID incidents in the coastal areas is based on hard data. I think we can quote the zero prevalence survey and because the granular data is available.
Yeah,
based on that. Yeah, that's
there is in health usually the attitude that we people, especially doctors and the medical people, are harboring, that disease is happening because of some fault from the person. They are not able to take this as a social reality, as a product or social product. Definitely, if you look at the seroprevalence surveys conducted at that point of time, coastal areas were affected. There is no doubt about that. Coastal areas were affected so fast and so severely compared to any other part of the area. There is no doubt about that data. But the problem is why the coastal area is affected. It is because of so many people. It is overcrowding is there. There is no, if you look at the population size of one PHC located in the coastal area, it is somewhere around 75,000. But in some other places, there is a primary health center for 25,000. In coastal area, there is only 2 ASHA workers are catering the 75,000 of population. I am quoting the example of Pundura. So this much facilities are very lacking, and needy people are more, and we are not investing anything. But then definitely the disease spread will be more. But at that point of time, we will have some kind of a data that disease spreading is more. We are punishing them for spreading the disease. And we have got that attitude that people are spreading the disease. We are not saying that it is our fault. We are saying that it is their fault. So that is the problem, I think, there. I think Rakhal sir may be able to explain more. I am not a very good person to explain this question, I think.
Dr. Agam, would you like to respond?
Yeah, very briefly. I can see a few hands up. Very briefly, I think, Dr. Devika, I think I agree with Anish in one way, in terms of, I think there is definitely a persistence in what you're saying of the colonial attitude. And I mean, I think I've seen this in health systems across the country. I've worked in Tamil Nadu for about 12 years, in Maharashtra for some time. And I think everywhere, the way in which doctors, especially as Anish rightly pointed out, a doctor-dominated, a biomedical-dominated, thing of actually victim blaming, of seeing individuals as ignorant, uncivilized, disobedient, problematic. I think that is definitely their, issues. But I would like to add 2 more dimensions, and the second, I think, is the caste class, composition of the doctors, traditionally. Of course, things are changing. And of course, things are changing quite a bit in Tamil Nadu. I at least Tamil Nadu, I know, I've seen it, and I have been part of various parts but early founding the early parts, and this was research done, for example, by D. Banerjee and others, that looked really at the dominant caste class composition of doctors. And if you actually look then at, for example, what Babasaheb Ambedkar talks about social nausea, and social, the disgust that we have, with the so-called, untouchables or the Dalits, I think, that is again, something I think we really need to look at. Most recently, Avnish Kumar has, written about this social nausea and COVID, and, quoting Ambedkar. Finally, I want to just add the one more dimension, and that is of the neoliberal form of governance, where the managerialism or the target achieved, the number of 5-star ratings, for example, then becomes so much more important to actually prove that you have done something, rather than actually, getting someone to say that, or actually proving an outcome. And we've seen this, whether it is, Swiggy or, anything else we use, everything is driven by the rating, and also the governments. Today, governments are so, as Sunil pointed out, one death, and they are just so frightened of the death that they are willing to send in the commandos, to avoid that death. And this whole, shall we say, domination, the sort of tyranny of metrics, as it's called, that is created with this neoliberal managerialism, as it's called, I think is another significant factor. Thank you.
Thank you, Dr. Rakhal. Dr. Sunil, again on the colonialism. Actually, when I mean, at the beginning, you thanked the indigenous people. I think it's a pattern in Australia, almost, because it reminded me of my fellowship days in the University of New South Wales, the Prince of Wales Hospitals, and the Black Dog Institute, where all the academic conferences used to begin with, thanking the, if I remember right, owners of the land. And in some of the meetings, even for academics, one of them, the so-called Aboriginal or indigenous people were invited, and in some of them they even chaired. So anyway, there's no meeting which doesn't begin with, thanking the owners of. That's a pattern, even in academic and research meetings. So that is there. So how do you respond to Devika's question on the colonial backlogs in the tribal context?
I will respond. See, I'm a storyteller, so I will tell you. I'll start with the last thing that you said. See, as an enthusiastic PhD student who learned acknowledgement of country and the importance of acknowledging that this land originally belonged to Adivasi communities. And this is a big issue in Attapadi, alienation of land. Not just Attapadi, but Attapadi definitely. I tried to do this once in Attapadi. I did acknowledgement of country, and I added the line saying that we are on traditional lands which belong to Irula, Muduga and Kurumba communities. 2 people came and met me after that and said, we understand your emotions, but we would like you to cross the border and go back with hands, legs, everything in order. Even to start with acknowledging, there is no acknowledgement. There is absolutely no acknowledgement in the communities. I think Dr. Anish and Dr. Rakhal have spoken adequately, but let me add one more thing. Yes, colonialism, but this whole process of dehumanization of vulnerable communities, it allows you to get away with anything. I mean, see, if my own positionality, I always personalize this to ask myself critical questions. I mean, I have to do that as a qualitative researcher. I have asked this question several times. I belong to a well-connected Syrian, Syro-Malabar Christian community from Kottayam. If any doctor, whatever be colonial, whatever you are, had done, tried to tie one of our girls and bundle them into the jeep and gone, maybe some of you are going to smile at this, but this is what exactly used to happen. We would know exactly whom to call. He's no longer there, he passed away, but the first call would go to a former politician in Pala. and you all know the name. And you know, the next thing that would happen is that this question will come up in the Kerala Niyama Sabha. I tried to get a journalist to go into Attapadi in 2020 and actually write the story of this woman who was taken by Thunderbolt commandos. And this guy scooted after that. I have been trying to at least give back the papers and everything. He said, sir, Kerala, I can't write it. So it's not just the health system and the doctors. It is also about Kerala
I want to
society as a whole.
Something clear here. I'm pretty serious when I say colonialism. I mean, I'm not trying to kind of blow it up and make it look sexier. I'm actually asking a very strong empirical. That is, in India, public health, when it was introduced by the colonial powers, treated human people here as exactly like unruly subjects who needed to be subdued by force, who needed to be pushed into healthcare systems for their own good. Obviously, the elites in colonial society would not have suffered that. That is so much certain. So likewise, the Syrian Christian community or the Nayars or the Nambudris in Kerala will never get pulled in or made to forcibly quarantine or anything of that kind. That won't happen. That I'm pretty much clear. I'm just asking if for the large majority of Indians who are marginal, who are excluded, on whose labor and resources we continuously prey, like the colonial power. I'm just asking, and so that's why I'm asking whether the structure and spirit, however much you may change the embellishments, is the structure and the spirit of public health in India, and even in a place like Kerala, which has reportedly changed so much. Is it still colonial? And that's what I'm asking. I'm not really, trying to sort of use a fancy term. This is a very clear historical question.
Sunil?
Yeah, the simple, straightforward answer would be yes, definitely. I mean, I have no doubts in saying yes to Dr. Devika's question. I mean, from my experience in Kerala so far, yes, definitely.
Let me add one more point.
Okay.
If you look at the Trivandrum situation, because I know about Trivandrum, so the new generation hospitals, almost all private hospitals are located in the coastal areas. I am not naming the hospitals, but if you look at the patients, these patients are not belonging to the coastal community. They are not coming from the neighboring population at all. What is happening in the neighboring population? They will collect fish and it will be sold to the people in the city. Maybe that means the fish is contributing to the micronutrient of the maybe the elite. But the hospitals located in their vicinity or their premises are for the treatment for this particular elite group. So if you go or in detail about the situation that is prevailing even now, it is just like colonialism. There is nothing. I think it is very clear.
Okay, thank you, Anish. Dr. Shubhashree. Okay, Dr. Shubhashree, there's one question to Rakhal. I think we'll take that up after Shubhashree's question.
Thank you. I'm sorry I missed Dr. Anish's presentation. I'm really unfortunate, my loss. But I heard both Dr. Sunil and Dr. Rakhal's presentations. I mean, I just want to add on to this, this discussion on colonialism and also bring in credit with the earlier presentations yesterday in the first session on gender and health. And this constant kind of, thread of stigma and dehumanization, which we heard about the fishing community in yesterday's presentation, and especially as related to their sexual reproductive health. And here again, so I actually therefore wanted to also bring in the thread of gender here. I don't think it is simple colonialism alone, but the colonialism which is been contextualized to the particular context of the current society, where gender and caste hierarchies also play such a big role. And I think that that complicates the matter tremendously. And Sunil, I was very struck with the term you used of dehumanization. And I think that is something that is absolutely at the crux. Unfortunately, when you showed that map, the cursor wouldn't work. So it was not very clear where those health centers were. But I think the point you were trying to make is that there were several functional health centers that would be able to provide at least basic level maternal child health care, right? Well equipped, well staffed, well functional. I don't know whether well functional, obviously not functional, but well equipped, well staffed, and potentially functional. I also wanted to hear this whole public, how the public health logic works. I mean, I'm a person, I worked in the area of maternal health and health systems. And I mean, the whole idea of institutional delivery is as a means to better maternal health. The institutional delivery is not the end goal, So institutional delivery is actually women coming to institutions for birth is actually promote better maternal health. And that seems to have actually become the end point and end goal, and the only goal that we measure, so much to the point that we're willing to actually bundle them and put them in jeeps and actually take them to an institution. So, I mean, I think there is a problem somewhere. So I mean, I don't know if I have a question, but the thing is that how do we actually move forward? I mean, what do you see as the way forward if you really want a health system that is humane and human and humanized in that sense, without these, caste and gender hierarchies? Obviously, there will be, because the larger society is riddled with them, and the health system is one kind of, part of the larger society that
Thank
it
you.
is. Mirrors
Thank you,
the
Dr.
institution.
Subhasri. Thank
Yeah.
you.
So my question, therefore, is what would be the way forward?
Okay. Before that, let me just take a query from Dr. Sunil Mani as well. Dr. Sunil.
Yeah. First of all, I think thank you very much for all the presentations. My question is basically to Dr. Gaitonde, and you see, isn't there a serious criticism of the data thrown up by various NFHS surveys? So, because you have been so confidently using them to show a survey, but while there is actually a serious conversation on that some of this data are not very reliable. And second, how does even if you assume that it is all fine, how does the outlier story of Kerala compare with other states? Because outliers may have made some improvements over time in other. So that's a question to you. And to Dr. Anish.
Thank you, Doctor. Thank you, Doctor.
No, I have one more question.
Okay.
To Dr. Anish, which is basically because yesterday John Kurian presented saying that, you see, for instance, in the Fisher Folk, the incidence of COVID and death rates due to COVID-19 is not very high. Okay, and we also know from other clusters, like for instance, plantation labor. Okay, the incidence of COVID-19 has not been very high. And so is that correct or not, or are we missing something there? Because you have been saying just opposite.
Thank you. Okay, thank you. Dr. Sunil, I think we'll first listen to Dr. Rakhal. There's one more question to you from chat box, Dr. Rakhal. Where does one start today, BP or IMR? Facilities, funds, and medicines alone are not adequate. Attitude, empathy, and the heart of the providers and institutions are key. Is Kerala's health system losing this advantage it once had? I think you can take all the questions together, Dr. Rakhal. And then we'll move to Anish and then to Dr. Sunil.
Yeah, sure. Thanks for the questions. I think Dr. Sunil Mani, I am aware of the debates on the quality of data that the NFHS is throwing, and therefore, that's the reason that I started off my presentation by acknowledging that individual estimates have their issues, and what I was hoping to do really is to look again at the visual, the sort of trends over time Okay, again, of course, I know the argument is that if the individual estimates are wrong, how do you, valid, or how valid are the trends? But I would have basically sort of two responses to that. And one is, of course, the fact that we do not have such robust or as systematic data that is disaggregated along the various issues that, along the various axes, that is freely available for us to have. And my point was really to generate a discussion on what these trends and gradients actually show. Now, there is a consistency in the gradients across the 3 rounds of NFHS, and I think the consistency and the sort of general trends, I think, at least point in a direction that is of major concern. And like I said right at the beginning, it was in that direction that I really wanted to take this discussion, rather than, of course, the actual statistical validity So I use the data again, not as the only aspect of my presentation. It was one of the aspects of the presentation. I didn't highlight too much on the institutional anthropology or the ethnography, because that was extensively covered both in the gender study, gender session yesterday, and Sunil's presentation. The second point I have in defense is that when I shared this presentation with a number of individuals before I came here, and I think, even here, none of this is quote unquote unbelievable. And the fact is, I think that there is a sort of gut, a feeling at least that by and large, okay, if not for the very individual sort of, fine sort of, percentage differences or whatever, this does make sense, right? So it is in this spirit that I actually use the NFHS data, that's the answer to your first question. The answer to the second question is what to the other, so-called outliers in other parts of the country, how they have said. There is an ongoing study we are doing here, and I definitely am aware of the sort of general argument that, actually Adivasis in Kerala are doing better than, for example, Adivasis elsewhere, or people in the coastal area, area in Kerala are doing better than, coastal communities other places, but that was not my argument. My argument is of subnational exceptionalism. And my argument was and is that in Kerala, we are seeing these things. And the question, therefore, is then, how do we reflect on the policy and the interventions in Kerala to deal with the empiric findings that are coming from Kerala? So that was my very, very specific focus. And we will hopefully publish this, multi-country, multi-state sort of outlier sort of thing as soon as it's ready. Thanks.
Dr. Rakhal, can I take a question from Dr. Filippo Osella as well, and then proceed with the other answers from other speakers?
So, ma'am,
yeah.
Ma'am, he had a question to me also regarding the infection rate in coastal area. Can I just tell that?
Shall we take his, was it the same question, Dr. Filippo? Or we can add that question and get all the answers together?
No, hello everyone. I'm sorry I could only join you today, but I'm in the middle of teaching. Yeah, I just had a comment regarding Devika's question concerning colonialism and the way in which colonialism dealt with public health. Now, as everyone else, for the last 3 years, I've been doing research in coastal communities in the Trivandrum district, also during COVID. And, what Rakhal was telling us about the commandos and all, and the response of the community was clearly a matter of big concern. But the comment that I had was recently there was an article by David Arnold looking at the relationship between, or addressing the relationship between the 1896 plague and the current COVID situation, and the way in which it has been dealt with very often in very repressive ways. And what David Arnold was suggesting was not only to look at the continuities between the colonial period or not, but to see, to ask ourselves the question as to why, in very, very different circumstances, we find a similar way of approaching public health, in particular during a COVID, a pandemic as we find now. What is it that connects different practices which emerge in very, very different historical periods? That is a question that I'm trying to address myself. I'm writing exactly about the way in which the COVID emergency was administered and governed in coastal areas. And
Okay, thank you.
Yes.
Thank you. Anish? Thank you for the question, Dr. Filippo. Anish?
I was actually trying to respond to the previous question. Was really the coastal areas were affected more compared to any other part of Kerala? Actually, it is yes, coastal area were affected. But if you look at the administrative data, it will not give you that picture, because as a group which is socially backward, the reporting was also less in coastal area. That was the reason that it appears that the same coastal area and the other areas are affected the same. Because I am saying it so authentically, because we were analyzing the zero prevalence data for the Kerala state.
You can briefly mention the methodology based on which the granular data was collected from the coastal, the tribal, the urban, and other.
We collected blood samples for each and every part of
based
the,
on
of the states.
ELISA,
And just like this, for example, people, if you look at the administrative data, you may think that COVID cases were more in Kerala compared to a North Indian state. But zero prevalence data very clearly say that Kerala was less affected, but the North Indian state is more affected. The same thing has happened in coastal area and other communities. In coastal area, the surveillance mechanism was poor. That was also some of the indicator of the backwardness of that area. But clearly, the COVID cases were more in coastal area. So yes, ma'am, finished. Thank you.
Thank you. I think now we can take responses from Dr. Sunil and wind up. I think I'll put some of the perspectives in place, Dr. Sunil, or you can first respond to the queries and then we'll have the final summing up. Dr. Sunil?
Was there any question? Did Shubha have a question? I thought it was more of a comment. But I mean, I think what I could sense from what Dr. Shubha mentioned was this whole thing about institutional delivery. I think this is over medicalization is generally a problem.
What is the way forward? That was another. I think you can talk about the way forward, because we have lots of. Let's talk about solutions also.
Yeah. So solutions basically. I mean, when it comes to marginalized communities, I mean, like I have always wondered, like, why does this happen with this community? I mean, in a health system, when a health system responds to different issues, different situations, different communities, marginalized communities, suffer more of dehumanization. Marginalized communities suffer more of lack of access to healthcare, access to various other resources. Health systems get away with a lot of things that they do to marginalized communities in the name of providing healthcare and access to healthcare. To me, from the work that I have presented today, one of the most important things is that the institution is not going to give anything on a platter to indigenous communities or to any other vulnerable communities. I think the most important thing that I have learned, both from the Australian context, where you will never get away with anything like this, you lose your license to practice, as well as studying the situation in Attapadi, is actually strengthening of the community. I mean, strengthening of the community and community processes, and institutionalizing some of these processes. Like, how can the community define what is quality of healthcare? A woman being tied up and taken and bundled and all of that, the doctors define it as quality of healthcare because according to them, the delivery happened in the hospital and it was free. But for the woman, she lost her dignity. And for 14 days, she was worried about her two other
So
children.
how can we address both these
Yeah.
together?
So,
There's a
yes, so
biological
therefore,
perspective and there's
the most
definitely a
important
strong
thing,
social perspective. Yeah.
yeah. So therefore, for all of this, I think the most important thing is strengthening the voice of the community within the public health system, and to some extent, at least, institutionalizing the involvement of community in some of these decision-making processes, mechanisms, and forums. So I would say that would be my take on going
Thank
forward.
you, Dr. Sunil. Thank you. Thank you. I think all of us know, like, we are all speaking the same language. This Center for Development Studies as basically the academic research policy and, data. Policy should be data driven. We speak the same. And it's also important that the academic institutions, research institutions, evidence, all these should not be, even the student community from undergraduate through the post-doc should not be separated from what is happening outside. So the data, evidence, perspectives, and finally there has to be some implementation. It's not that someone else is implementing it. So that's why the activism also, I think Devika is an activist, Anish is also a public health activist. Most of us also engage in community in several ways. So it's really important that that community engagement also happens, and the community has to be placed in a pivotal position, and their perspectives are really important. And that is a way in which governance can take over. Though Australian context may be a little different, there is a strong perspective in it. There's a sorry day in Australia, Sunil, if I remember right. One day, just like our independence, or it's not that Australia has lots of things we should emulate or copy. Just mentioning there's a sorry day because we have taken over. So just by acknowledging that, it is your land we are using, you are the owners. But apart from that, really important that, and as we know, recently we were in a tribal settlement near Achankovil where a rabies girl, a +1 student, had, because we know that tribal people, I mean, not really there, like everywhere, dogs, evolution, again, historically, dogs are so close to us. And investigated, actually, we are taking our undergraduates and all their 7-semester research. The 2018 batch will be conducted there. And the emic and ethic perspective, we usually teach them, both the undergraduate and postgraduate. Actually, they should have that feel. We may call it empathy or not, but then that anthropology aspects, living with them, those kinds of experiential learning will definitely, enable our young doctors, young nurses, young public health professionals, developmental activists, economists, that perspective of the society. I think that part is also important, that breaking those barriers, as Dr. Rakhal said, breaking the barriers of not only departments, sectors, social science, medical science, basic science, those sectors. I think it's also the responsibility of the academics and research institutions to move on those directions with an open mind. Definitely, data is not only the hard data in terms of numbers. It's difficult to quantify perspectives by numbers, but again, that qualitative kind of research and data also, lays on with the policymakers. Dr. Chidambaran Iyer, I think my time is just coming to the close. Shall we have 1 minute each from each speaker? Dr. Anish?
I do not have anything
Summarize
to
your
add.
views. Okay. Dr. Sunil? You're mute, Dr. Sunil. You're mute. Will you unmute and
I was
speak?
just saying that Dr. Indu, you have given a really good summary, both from the community perspective as well as from what can we do with regard to students, future medical professionals, and all of that. I think that would be a good summary for
That
me
is
as
a
well.
very
Nothing more to
important
add.
point. കാരണം ഇതിപ്പോ ഡോക്ടർ ദേവിക പറഞ്ഞ പോലെ ഇപ്പൊ നമ്മൾ ആര് നിങ്ങൾ മാറിയിട്ട് ഈ നമ്മൾ എന്നുള്ളൊരു ഫീലും അവര് നമ്മളെ സർവീസ് പ്രൊവൈഡ് ചെയ്യാൻ പോകുന്നു, നമ്മൾ ആശുപത്രിയിൽ നിന്ന് മരുന്ന് കൊടുക്കാൻ പോകുന്നു. ആ ഒരു ഐ തിങ്ക് ദാറ്റ് ഇസ് നോട്ട് ഓൺലി വിത്ത് ഡോക്ടേഴ്സ്, ഐ തിങ്ക് ഫോർ ഓൾ everyone else in the community. Dr. Rakhal?
Yeah, thanks. Yeah, I agree that I think we need to move forward, but I think we need to ask some deeper questions, than ask it, in a superficial sort of way. And I think the question that Devika asked is extremely important, and I would even talk about, for example, newer ways of looking at colonialism, what is called settler colonialism, for example, or what is known as internal colonialism, for example, and acknowledge the fundamental economic model that extracts resources and therefore has to create this dehumanized groups in order to continue extraction in an unsustainable way, because health systems are, after all, as Sunil rightly pointed out, social institutions. They emerge from a certain social power hierarchy. They don't evolve in isolation, in vacuums. So even as I completely agree there needs to be this engagement and so on, I think these sorry day, as you mentioned, or the acknowledgement that Sunil made, are not symbolic. They are very real, right? Social acknowledgements. They're not individual level symbolic check boxes. Until that happens, and how that is going to happen at a social level is not for me really. I don't have that answer. I think it's something collectively that all of us need to really engage with. And I think this sharpens when we start not looking at two opposing views, but a human right view. And then if we ask the question of what is the human rights angle to this whole question, I think things become slightly differentiated and much more clear. So I'll stop with that, with the ardent hope that I hope this session generates better and more discussion in more ways. Thank you very much for this opportunity.
Thank you very much, Dr. Rakhal. Once again, gratitude to all the three speakers, Dr. Anish, Dr. Sunil George, and Dr. Rakhal. And my special thanks for giving me an opportunity. It was a wonderful session. We look forward to such sessions. Thanks again to all the organization from the Center for Development Studies, Dr. Devika, Dr. Sunil, Dr. Chidambaram Iyer, and everyone. Thank you. Bye-bye. Good day.
Thank you.
Thank you all.